Good afternoon, everybody. Um, so I'm on Twitter, and you don't have to follow me. I'm there just because I like to say things. But I follow a lot of physicians on Twitter. I didn't used to see doctors on Twitter because it used to be like not, it's like keep your privacy about your practice. But there's a lot of people talking about their practice. And this was a cute story I heard. So this patient, it sounds like a joke, but really it's a true story. It's 140 characters, so don't worry. This patient woke up from surgery, and he said, "Is it over?" And the doctor said, "Yep." And the patient said, "But I didn't count backwards." And the doctor said, "I never ask anyone to count. It's so cliche." And the patient started to cry, "But I wanted to count." And the doctor, "Well, you can count now if you want." The patient muttering, "It's not the same." And the doctor said, "I'm sorry I ruined your anesthesia." Here the doctor's saving this person's life. The amazing thing is happening. And what is the patient going to remember? "I didn't get to count backwards." So we have all these expectations about how things should go. What are our obligations? What does risk say? What does medicine say? And sometimes it's the simplest thing that matters, right? And that affects your scores and everything. And I just was so touched by that the doctor tried to fix it, but he couldn't reverse that small issue. So I just thought it was kind of cute, and I figured I'd kill time while everyone else was getting their food. Okay, here we go. So we are going to talk about noncompliance, and I did like this study. They came out and they found that there were three groups of noncompliant individuals: the accidental, the invulnerable, and the decisive. The accidental is just that. They just forget. They're not trying to be difficult. They're not opposed to the plan. They just forgot. And so what they found is, with this group of individuals, the way you could solve it was to attach some new, because they had it set up so, you're doing, okay, great. There's things happening all around me. The way you can help solve this for this group is to attach the new behavior to something they already do. So I've heard doctors say, when you wake up in the morning, I want you to take your pills. Like when you're brushing your teeth, try to remember to take your pills. What's wrong with that example? That's assuming that they brush their teeth, right? And that's assuming they brush them in the morning versus I brush mine after breakfast. So if you wanted me to take my meds before I eat, that plan is not going to work. So what you need to do is ask the patient, if you're going to attach it to a behavior they already do, what do you do first thing in the morning? And I always turn on my computer, right? So I keep my medicine right beside my computer. Attach it to something that's actually a workable plan, not what you think is best, but what the patient is willing to do. The second group was the invulnerable non-complier. And I like this group because they believe that all those bad things that might happen won't happen to them, right? If other people will have side effects, well, I just won't take that because I don't want things to happen to me. Other people might get sicker if they don't do their diabetes medicine correctly. That won't happen to me. And so what they found with this patient, they found that written information seemed to help more than dialogue. For some reason, if it was written down, the patient would follow it. I don't know if it's in writing, it's real, right? Because people think everything on the internet is real because they can read it. So for certain people, writing helps a lot. The decisive non-complier, that person, they're not going to buy into the plan because you said it. They're not going to do it just because other people say it or it's written down. They want to make their own decisions. They're very independent. But the good news is if you give them good quality information, they'll probably buy into the plan and do it because they feel confident it's the right thing to do. So right away we see that you got to adjust the plan based on how they're willing to implement it. These three categories are very helpful, but I find that there's a lot of other categories, and I'm sure you deal with these all the time. Illiteracy. 24% of the population in California reads at a third or lower grade level, right? So when you hand them those instructions, right, yay, give papers to people, they'll read it, that's assuming a lot, right? Because a lot of people can't read or they can't read in English. Medical illiteracy. I used to be an ultrasound tech, and at that time the patient could see the screen of the ultrasound machine, and I'd be scanning the abdomen, and I'd say, well, there's your kidney, there's your pancreas, and they'd be like, oh, what's wrong? I'm like, no, it's your pancreas. They didn't know they had one, and so they thought it was like a tumor or something. People have no idea what's going on inside their body. And so we can't make assumptions that they understand what we're saying because they don't even have a baseline. Grief, denial, fear, frustration, all the emotions can get in the way. Pain and fatigue are a big one. I don't know if you've ever had to deal with chronic fatigue or chronic pain, but there's only so much energy in that day. And for somebody who has chronic illness, they just have this little bit of extra energy to get through the medical plan. And if the plan is too much to do or their pain gets worse, they can't deal with the plan. So maybe getting good pain management on board could help them with the rest of the medical care. Financial, that's a big one. A lot of people cut their pills in half and take them every other day to make them last longer, right? Or they literally don't have transportation back to see you for follow-up. Or they can't get on the bus because they are in a wheelchair and they don't know about Medi-rides, right? There's all these other things going on. Different cultural values. We'll talk about that in a few minutes. No decisional capacity. My dad, he had dementia, and I didn't understand what that meant years ago. I'd fill up his little pill box for him, and I'd come back, and he hadn't opened up some of the days because he literally couldn't remember to go to the pill box to find the one to then open it. His doctor had no idea he had dementia because he was charming and delightful and could still tell a joke, right? But he couldn't think and remember things like that. Irresponsible. This is one of my favorite ones. We expect people that are irresponsible in every other area of their life to all of a sudden behave and do what we tell them. That's just not going to happen, right? Substance abuse, coercive forces at home, being asked to do more than is even possible. A friend of mine is a dialysis social worker, and she said that they looked at how many extra hours a week it would take for someone to implement a good dialysis plan. I mean, so we have those days you go for dialysis, 3 hours there, plus transportation time. But there's all this other stuff that has to be done, including all the exhaustion and the extra sleeping. They said maybe it's about 3 hours a day on average. How many of you can add 3 hours to your schedule every day? Right? So they figured that maybe we could adjust the plan and make it only 2 hours worth, right? Because it has to be reasonable. We want what's ideal in medicine, but we got to deal with what's realistic. A lot of times people are difficult because they're angry at their disease, so therefore they're angry at you, or there's just not enough time. Most people cannot learn as fast as we think they can, and in medicine, everything's become a time pressure. It's like tick-tock, tick-tock, go, go, go. So we got a lot of things to get around, but the good news is we can. So let me ask you, I need your help with this. Why isn't the patient taking her medicine? Whether it's an injection for her diabetes or taking her oral medicine, why isn't this lady taking her medication? What are some of the reasons? Yes, sir. Insurance won't cover it, right? Some medicines are really expensive now. What else? Yes, sir. You're the star pupil back there. They're fearful of the needle, right? I have a relative like that, yes. What else? Denial. I don't even have this disease, right? That is one of the most common things. Why would I need to do this? I don't feel sick. I don't need this, right? What else? Yes? Oh, in the Hispanic community, he said that a lot of people believe that once you take insulin, that means kind of like you're the end of life. You know, you're actually going to die soon, not you're actually going to live better, right? And think how difficult that is. How do you navigate that? What other reasons? Why don't people take oral medicine? Sorry? Can't swallow pills, or don't like the way it tastes, don't like the side effects, right? It gives me an upset stomach. What else? Okay, I'll go with you. Oh, they read the package insert. I have an aunt that does this. After she reads all the scary things, she can never take a pill, right? Because she does not believe it'll happen. She thinks it all will happen to her, right? She has a very big mind-body connection of perspective. So we have issues with insurance. We have people that can't swallow it, or they don't feel well after they take it. They're scared of needles, or culturally there's issues. Do you notice that these are very different problems? Therefore, very different solutions are needed. How you're going to solve the insurance issue is going to be very different from how you might be able to help them with their cultural concerns. You may not be able to get past that, but at least maybe you could try. Maybe they could cut the pill up in smaller pieces and take it. There are solutions many times, but you can't begin to guess what the issue is. You've got to ask. And this is a technique we use in mediation. It's called learning the difference between position and interest. In mediation, what we try to do is when somebody says, I don't want to do that, I'm not going to do that, instead of arguing with them and say, you should, right? And then we just get into a battle. You should do it. I don't want to. You should do it. What we do is we say, okay, can you explain to me why you think that, or why that would be difficult? And then they might say, I'm scared of needles. I don't like the way medicine feels. I can't afford it, right? I can't get to the pharmacy. Nobody will drive me. Because the thing is, the interest is what's really going on. The position is the one they take. They make a statement. The interest is the real reason. And once you know the real reason, you are great problem solvers. You may be able to figure out a way to get around the issue. Maybe you can get a special price from the insurance company or contact the drug manufacturer directly. Maybe you can arrange for a ride, a medical ride to the pharmacy. Maybe, I don't know, but you cannot solve a non-compliance issue if you don't know why and what the reason is, okay? So I wanted to ask you, because I did say the word non-compliance, and I know that there was a change in word many years ago that we became non-adherent, right? But no matter what, we're nons. We're not good. We're not okay. How many of you in here do everything your doctor says? You all have your cholesterol under control. You've stopped smoking. You all ate the vegetables today, right? Nobody had dessert. You take all your medicine on time, yes? Excuse me, where are your hands? You're non-compliant. You're the problems, right? And I say that kind of jokingly because instead of us looking at these patients as problems or the difficult patient, this patient doesn't come in, they don't do what I say, they're a problem. Wait, they're me. And maybe if we partner and we figure out what could we do together to solve this? How could we work this out? How can I help you? Because it's us too. All right, so that's one of the ways to kind of shift our understanding. So that brings me to something we talk a lot about, shared decision making. This is a great way for compliance issues. What do you think are your biggest problems with implementing this plan? Would you like more time to think about it? A lot of times people aren't ready to buy into the plan, but they'll say yes just because they know you want to get out of the room fast. I know it might be hard to do this. Let's talk about what problems it might create and let's work it out together. Maybe I can give you some solutions or help you get access to resources. I know, this is my favorite one. This is the ideal plan. I really would like you to do this, this, and this. That's the best plan I can offer you. Would you be willing to do any of that? Because if they're not willing to do it, that means they won't. Therefore, the plan is not really a plan because they never plan on doing it when they get home. So in mediation, we use this phrase, would you be willing? It works really well. Let me give you an example. If you say to Vicki, Vicki, can you stop eating cookies? Yes, I can. Ask me the other one. Ready? Vicki, are you willing to stop eating cookies? I don't know. Do you hear how different that is? Language is powerful. Sure, I can do this, but am I willing to do it? That's where you'll find out if the plan has even a chance of working when they get home. You don't ask, would you be willing in the early part of the conversation? When you think that you're offering this ideal plan, you check in. Would you be willing to buy this medication and take it every morning when you turn on your computer? Would you be willing to come back and get an x-ray? Right? Because if they say, nope, I'm not willing to, redesign the plan. Don't be mad. Just figure out what one thing could they do. It's better than nothing, right? Okay, so this is very helpful. Would you be willing is the mediator's friend. All right, so I know that I'm talking to risk managers mostly in this room, and you would like the world to be black and white. There are rules, there are regulations, there are laws, and people should do the right thing and not do the wrong thing, yes? Anybody would like that? Yeah, that would be great, right? But the world is very gray, and we cannot always get people to cooperate. And in that gray lives a lot of cultural issues. Just like we heard you say a few minutes ago, you know, this needle and this insulin means I'm at the end of my life, right? How are we going to get around that? What else is included in culture? Culture could include the actual ethnicity, race, where the person is born. It could include the religion. A lot of religions have strong rules about what you can put into your body, when you eat things, what you don't eat. It also could include what generation they are. Are they a boomer versus a millennial? You know those millennials, right? Are there any millennials in here? Yeah, you know those problem millennials, right? I'm joking because millennials have incredible talents. They're very different than a boomer, but both groups have things that they do very well and things that aren't as easy for them. But that's this judgment. That's bringing in culture and all these opinions we have to say, you already are losing as far as I'm concerned. I don't like your religion. I don't like your culture. I don't even like your generation. Maybe I don't like your gender, right? And so when these things pop up in your head, you're allowed to have all sorts of opinions, but you're not supposed to act on them. You can use that information to say, wow, is there any way that I can be more inspiring, more encouraging for someone who is a millennial? Do millennials do medicine different than boomers? Do you think there is any difference? Would anything motivate you differently than if I talk to a boomer? Yeah, you're the only one here. What do you think? Right, so if I give you an app, right, maybe have you play a game that helps you remember to do things. I don't know. See, I have no idea. And since I don't know, I'm going to ask. That's always the solution to culture. Ask, because everyone is not exactly their culture either. Let me know if you ever think of other things specifically, because I would like that insight. So here we go. I was told we had to talk about cultural competency. And guess what? That word has fallen out of fashion. Just like non-compliant became non-adherent, cultural competency is actually a great idea, right? The more you learn about cultures, the more you understand, you are more appropriate, like even in your interactions, how you talk to the person, how close you sit, do you make eye contact? Cultural humility is this new word. Has anyone heard this one yet? It's really popular, so you're going to hear this one more often. At first I heard this word, I'm like, what? What is this word? What does this mean? And it took me a while to embrace it. And recently I realized that, oh, I get it. Cultural humility is approaching a conversation, an interaction with a beginner's mind. I don't know who you are, what makes it better for you, what might be a limitation for you, what you need for us to partner and make you help you get better. I have a beginner's mind. I'm going to ask more, and I'm not going to make assumptions. There's a certain amount of humility that I walk in that door not prejudging. And I had an amazing experience recently, personal story, cultural humility. I've been thinking a lot about my culture as a woman, right? There's a lot of women's issues out there, right? And so I was thinking, I've explained to like a lot of my brothers recently and other men in my family and friends that it's tough to be us, right? There's always a certain amount of fear. We don't walk down dark alleys. We carry our keys in our cars to our car because you don't want to be fumbling in the dark to get your keys out. We worry about a drink, that someone isn't going to put something in it, right? There's a lot of the culture of gender excellent, those are good bells. There's a lot about the culture of gender that, he's ruining my story here. Okay, there's a lot about gender that affects who I am and who many of you other ladies are. Can anyone relate to these things? There's a certain amount of fear just being a woman, all right? And then I listened to another speaker, and he was an African-American man. And he started talking about what we don't get about his experience. And he said, you don't get it. You don't get that every morning I have to wake up and I have to put on my I'm not going to steal from you. I'm not going to harm you. I have to put on this mask that I do my best to be as non-threatening as I can be. Because if I walk into a store to buy something, the security guard is going to follow me around as I'm shopping. That if I do walk down a road late at night, anyone that's walking toward me, they'll change sides of the street. That this person literally has to put on this coat of, I'm trying not to be threatening. I'm trying not to even just be who I am, which is just a person. And I am always worried. I am always fearful because you're afraid of me, and I'm afraid of what you're going to do to me because of that. That's cultural humility. I didn't know that story. Maybe I should be embarrassed that I didn't understand it to that degree because I was so worried about me and my issues. Cultural humility is leaving the space for someone else to tell you their story and for you to understand that it is not as easy as just take your medicine, just go to the pharmacy, just do what we're saying. Cultural humility, okay? That is the... I think this is going to help me a lot, the new word. It did take me a while to come to terms with it. It also makes me have a lot more openness to what other people are going through. And I usually am open, but I'm even more so. Okay, so why do we have P's here? So I took my mother-in-law for her knee surgery. Right? She's in her 60s, maybe late 60s, and I pick her up from the hospital. you know, they give you the person really quickly to take home, right? You don't get to keep them overnight. So I've got her in the car. I have these magic papers that they've given me, the discharge planning. This is like 20 years ago. And I'm going to now get her home. I get her settled in her bed, and I pull out the papers. I'm like, let's read what we're supposed to do. And it says, put the frozen bag of peas on the knee. I'm sorry, what? Put the Wait, first off, I'd never heard of this 20 years ago. I'm like, we don't have peas. Nobody told me I needed peas. I'm not allowed to leave her for 24 hours, right? Because she's been under sedation. I can't go to the store and buy frozen peas. Why didn't anyone tell me? If they told me when I dropped her off in the morning, if they told me at her pre-op or her ortho appointment, at any time, even on the way to pick her up, somebody should have said, this is what you need to get. This is the reality of being the family caregiver. I've been a family caregiver 6 times. I've been through a lot of these moments, and now what I do is I actually ask for the instructions, the post-op instructions, early on. I think we should be doing this. I know they may have variations, but the generic, when you get home, you're going to need to elevate your leg. You're going to need ice. You're going to need to have frozen peas. You're going to need, I don't know, tell me, because I'm not that medical expert, right? So you have to explain to people in enough time so they can be prepared to have a good outcome at home. What I need to do, what supplies I need to get. I need 3x3 gauze. Oh my goodness, I don't have that either. Right? How many of you give any kind of discharge instructions before the surgery? This is a great idea. It has helped me a lot now. I just took somebody for a different appointment, and I said, just give me the generic. I know you're going to change it, but I just want to read it because it's like 3 pages long, and by the time I get the person home, there is no space and time because I will be constantly, are you okay? Do you need something? Let me read it while you're sitting there operating. I'm sitting here for like 2 hours. You might as well let me read this stuff. Right? And then if I have questions, I can ask you now instead of when things are falling apart. Right? You can also make sure that the doctors, can they talk about informed consent, not just about the procedure? And I know that's what informed consent is all about, but what are they consenting to during the recovery? Right? I know you're worried about the hours that they're in the hospital, in surgery, in recovery, getting discharged. But if you really want good outcomes, tell me how much pain I'm going to be in. Don't say there'll be a little discomfort. How much pain is that usually? Does anyone know? It's a lot more, right? Just tell me, because then we can make sure we got pain management on board. Maybe I can have ice. Maybe there's other things I can do. Maybe I can meditate and calm myself so I'm not focused on the pain, right? The more you can explain the whole journey to a patient, the more likely the whole journey is going to work out, right? Because I know the hospital is worried about readmissions, right? But if they don't know what to do when they got home, then how is it going to work? They're going to come back, okay? Another technique that I've taught physicians is there are always the typical questions that even though you told them, those typical questions that people will call the office with after the procedure or after the surgery, right? And maybe you can make a frequently asked questions, and I would label it for a good recovery, or to enhance, to give you a better chance of a good recovery, and give them those main points that you know always become a problem, right? And then we have to worry about it in different languages and different reading levels and all that, but you got to explain. The other thing that happens to me a lot of times when I'm going to pick up a loved one after surgery or a discharge is that the nurse says, okay, I'm going to go over this information with the patient. Why don't you go ahead and get the car and I'll send her down. And I don't know if this still happens, but you are sending the one person who has capacity at that moment, right? The patient is on pain meds, somewhat sedated, not thinking clearly, certainly not focused on what the nurse is saying. They just want to go home. And you've sent me away. 2 ears, more ears are better. Instead of sending me away right away, say, I need you to stay here. We're going to go over these instructions. I want you to ask questions because we want it to be interactive. If you just read to them, okay, when you get home, I want you to put the frozen peas on there. You need to take 2 of this. Make sure you elevate. Blah, blah, blah. It's not going in. Interactive. Check in with the person. Find out what they're understanding. Find out if they, if you're doing all the talking, it's not a conversation, right? Interactive. Does it take a little longer? Yes. You know, and that's something that I can't fix for the healthcare system. But you are here because you don't want those risks. Somebody goes home and has a bad outcome, they still think you're responsible, right? Because it's not just about that it happened here in the hospital. If the recovery doesn't go well, what went wrong at the hospital? What did that doctor do? Those nurses, right? Give them the best chance possible. Okay, and the problem is that communication really isn't happening. I don't know if you saw this study. This was with older patients. They asked older patients as they were literally leaving the doctor's office, what did the doctor tell you? And they found out that 40 to 80% of what the doctor had actually said had fallen out of their brain, and what they did remember, about half of it was wrong. Did you know it could be this bad? Yeah, some of you are like, oh yes. I mean, does this scare you? I mean, what's the chance of us actually helping these patients? You have a good protocol. You have a good plan. You are investing the time and effort, and they still don't get it. This is a big issue, and it doesn't just happen with older patients. I remember my husband and I went, and it was for my appointment, and we're walking back to the car, and I'm like, well, wasn't that interesting that the doctor said? And he's like, that's not what the doctor said. I go, no, I'm sure that's what the doctor said. I was taking notes. Well, I was taking notes, and that's not what I heard. We are both educated, capable people, speak the language. Everything should be in our favor, and we can't get it right. So, what can we do? We want to start talking more holistically, not just speaking at them, but being more visual, more kinesthetic. How many of you are more visual learners versus auditory? Like you like the pictures and the handouts. How many of you are more visual? Raise your hand. Look around the room. How many people that is? And how many of you are more auditory? Look how few of us there are. I'm auditory. Anybody kinesthetic? You really have to do it. Okay. Everyone uses all of it. It's not really an only this, but that the preferred way, most of you were visual. How much visual conversation are you having when you're doing the discharge plan? Do you guys use any visual tools in the practice? How about videos? Do you have any videos you show the patient, like what to expect before your cardiac cath? Like a little story. See, that's how most people learn. So I encourage you to figure out what can we start doing to be more visual. Videos. Handouts are good if they can read. Maybe you can make it more experiential. Like one of the kinesthetic ways that can help is, say you want the patient to take their medicine a certain way, and you don't think it's actually getting through to them because they're not listening. You can say, okay, imagine this is your bottle of medicine. I put some M&Ms in there or Skittles or something in there. When you get home, tomorrow morning, what are you going to do? Show me, right? Can they open the bottle, right? I have a bad wrist. I literally can't always open bottles to get the meds out to even take them. All right? And they say, oh, I get up tomorrow morning and I take one of these. No, you actually take 2. I take 2, yeah, BID, 2 times a day. Oh, I thought it was once, 2 times a day, right? Have them actually role play. You know, a great way you can say this is, when you get home, what will be the first thing you'll do? Tomorrow morning, what do you expect and what do you think will happen? Right? So how can we inspire this person to kind of act it out? The other thing we can do is use the explain back, teach back method. And this has been around so long. I don't know if we still use it. We should, because it's a quick way to check, did it get in? Did anyone listen to what we said? So if I say to you, I would like you to stop your aspirin 10 days before the EGD and don't eat or drink the night before. Who can repeat back what I just said? You're all staring at me. I'm sure you were listening. Okay, go.
Stop your aspirin the night before, 10 days before.
Okay, did you hear him? He said, stop your aspirin the night before. He told you he was non-compliant, right? Go ahead, keep going. You're adorable. Thank you. Yes. So stop your aspirin 10 days before, okay.
Nothing to eat the night before.
Good, and not drink. Okay, so what am I going to do as a follow-up? He got it. I'm going to say, how will you remember? I'm going to always say, I have a hard time to do this because I don't want it to ever be about, you look like an idiot, you probably won't do it, let me ask you. Versus, I'm always going to say, it's called normalizing it, I would have a hard time remembering 10 days before to do something. Is there anything we could do to help you remember? Do you have a calendar? Should you send, can we write it down? Can you send yourself an email so when you get home? Is there anything I could do to help you remember 10 days before? Alarm in my cell phone. If you know how to set an alarm and you can do it 10 days before, see, but instead of me guessing, I did not guess that's what he was going to say. Did you know he was going to say that? Of course not. I asked, I checked in. What would help you, right? How long did that take? Not that long. I mean, we dragged it out because we were having fun, but not that long. And if he shows up for his EGD and he's not prepared because he didn't stop his aspirin, what is that loss of time and money to this organization and the consequences to his health because he won't have the right treatment earlier, right? We won't know what's going on. All for that 10 seconds, 30 seconds of interaction that could have laid the groundwork to have it better. Our dear friend Danielle here, do you know Danielle? She told me that her compliance has really improved because her doctor gives her a chart to do every day. When you are at home, I want you to check off these boxes, take your vitamins, do this, make sure you, and she feels so happy because she has the chart, and then she brings it back to the next appointment, and then the doctor says, good job, right? Because that motivates her. She loves the rules. She likes a chart. Other people would say, I'm not going to fill this out. Are you kidding me? I'm not a child, right? I don't want gold stars. Well, how are you going to remember it then? I don't know. Let's find out. I would do the same thing. I love the charts. Anyway, here we go. So the other thing that you can do and explain back when you check in, I love this. When you get home, what will you tell your family about what we've discussed? Because you know, the minute they walk in the door, someone's going to say, so what did the doctor say? And have you ever taken someone home and watched them say that? And you were at the appointment and they say, oh, the doctor said I'm okay. And you're like, no, he said you have diabetes. You need to take medicine. I think he said I'm okay. I might have to take some pill or something. Okay, no, right? This is the reality of who you're dealing with. All the ideas about this perfect plan and this perfect way you can get people to cooperate, we have to go down to a really human level, right? And I tell you funny things to make you laugh because it is funny, but try to keep a straight face when people tell you ridiculous things, because they will. I wouldn't have actually laughed at you earlier if I was at the doctor's office. Okay, here we go. Well, if I had a good relationship because we had known each other a long time, but you see a lot of new patients. All right, so this is a great example. Show me, walk me through it. Tell me what you're doing, especially when someone has already proven that they're not compliant. Tell me what you're doing instead of a lot of judgment like, you're not doing the right thing, you better show me what you're doing. Just say, tell me how it's working for you. What's working for you, what's hard for you, and let them talk it through with you. That's reinforcing it. It's becoming part of their memory. Okay. The other thing is to make conversations more visual, because you can't always have videos and pictures, is to talk about it experientially, right? So one of my common questions I'm going to ask when I'm working with a family and they're making medical decisions is, what will it feel like and be like for Bob to go through a colonoscopy? How many of you know what it feels like to go through a colonoscopy? How many of you know what it feels like to prepare for a colonoscopy? Most of you are not raising your hand. So when the doctor says you need a colonoscopy, you don't understand what you're signing up for. You're going to drink a gallon of liquid and explosive things are going to come out of you. Right? I mean, you have to have somewhat of a conversation. Some of you just looked rather horrified at me. I'm sorry. That's colonoscopy, right? Okay, so what's it going to feel like to go through chemo? What's it going to feel like to recover from this surgery? I know informed consent, we're worried about the law, benefits, risks, and alternatives, benefits, risks, and alternatives. I believe it should be, here is an alternative. Let's talk about benefits, risks, and burdens. Suffering, what it's going to be like. Here's the next alternative. Benefits, risks, and burdens. Here's the next alternative. Benefits, risks, and burdens. A lot of times what physicians will do is they'll say, here's the benefit of this alternative, and here's the risk over here of this alternative. They're not comparing like apples and oranges. There should be a quality conversation about each of those so people can choose wisely and know what to expect. The other thing is we want to talk about what will it feel like for the patient if he follows the plan, good and bad, or what does it feel like if he doesn't follow the plan, good or bad. All right, so I want you to try this little exercise with me. So we're going to either call it pleasure if I choose, or positives, or good things that will happen if I choose to do the thing that the doctor's asking, versus pain or negatives, or things I won't like if I actually follow the plan, or pleasure, positives if I don't do the plan, and negatives if I don't do the plan. Okay, you ready? You get to help me, and you're going to practice exploring questions. Ready? Here we go. Help me. I need to lose weight. So you're going to take a piece of paper. You're going to fold it in 4 like this, a blank piece of paper, and say, let's make 4 boxes. This is a great exercise that has helped a lot of my patients. I even use it, right? Because then it's not like just you, lots of people. Then you have your little boxes, and you can say pain or negative, whatever you want. And then you can start talking to them, but then probably let them finish the rest of it by themselves. Right? This might be a 2-appointment conversation, and that is okay because we got to get them to buy in. So what would be the positives if I actually started to lose weight? What would be some of the positives? Throw some out. Here we go. What? I would feel better. Okay, what else? What? A new wardrobe. Okay, what else? Right. I would like you to do these exercises with people that you, or ideas that you're trying to sell to patients. And imagine what they would say, because feel better, I would like that. That would motivate me. Now, we haven't done the other boxes yet, right? The new wardrobe made you smile. That sounds like a bad word to me. I hate shopping. I don't want to spend the money. Some people would say I don't have the money, right? To get a new wardrobe would be actually a problem, okay? I just hate shopping. So positives, I would put in the box over there, right? Feel better, right? Pain if I choose to do it, the new wardrobe shopping. All right? Don't make assumptions. It's good to imagine, but then let them choose where the box, which box it goes in. What else? Anything else? Pains or like, oh, negatives. I can't eat everything I want. Right? Any other positives? I could stop certain medications. Right? I don't know. You have to ask. All right? So how about pain or pleasure if I don't lose weight? What can you imagine? I know you don't know me, but what could you imagine if you were doing this with a patient? What might they say? I could eat my favorite food, cookies, right? Okay. What else? That would be positives if I don't lose weight, right? What else? No shopping, right? Because sometimes things go in both boxes. No shopping. Okay, what else? Because you guys are always trying to sell this whole lose weight, exercise, get healthier, right? How can you begin to motivate people or help other doctors and people motivate people if you don't have a sense of motivators? Do you see what I'm saying? Because you can't begin to say why. You can ask, that's probably the first place, what makes it hard for you to lose weight? Well, the healthy food, my family doesn't cook healthy food. They cook a lot of Southern food, right? That new study that just came out that the South, their food is very unhealthy, right? And that's all we eat. Well, could you start cooking other things? Really? That would be hard because, that's what we eat. That is our culture, okay? Here's a negative. You want to know something that would motivate me? Anybody want to ask me what would motivate you, Vicki? What would motivate you, Vicki? Okay, I try to practice this in your mind. Here we go. I don't want my husband, who I adore, to have to be a caregiver. I don't want to stroke out and have his life changed because I know what a caregiver is, taking care of 6 family members. I would not want to do that to him. It doesn't matter how long the list is. You might have 5 things in the pleasure. I'll fit my clothes better. I can go to Disneyland and fit in the seats. I don't know. Doesn't matter how many things there are. Whichever box holds the most weight for that person, the most importance, that's where they're going to live. And until you can find something that's going to motivate them from one of the other positive boxes, they're not going to choose differently. I don't mean to be defeatist, but this exercise helps them become more self-aware. Oh, I never thought about that. Oh, wait, there are other things that could motivate me to do the right thing. Okay, so here we go. Why won't this senior use his walker? I look old, right? I feel old using it. I look old. It's awkward. Maybe it's the wrong height that hurts my shoulders or it hurts my hands. Any other reasons you can think of? Humiliating, right? Now, do you hear that loud word? That was different than I look old. Humiliating is a much bigger word. That's when you say, wow, that's got to be really hard, right? This is really difficult for you. All right, so I'm going to show you a neat little technique you can use to inspire cognitively healthy seniors, right? I cannot necessarily fix, okay, good, I'll hurry. I cannot fix people that don't have capacity. I can't have a rational conversation. I can inspire them differently, maybe encourage them, do it with them. But cognitively healthy, this guy is amazing. His name is Dr. David Solie, and he has a great book called How to Say It to Seniors. I've listed it in your references. And he literally knows how to say it to inspire the senior to cooperate. And basically what he says is we all have developmental stages. Developmental stages, like little children learn that when mommy goes away, she'll come back, right? Object impermanence. There are teenage years, there's empty nest, there's all these different stages or developmental tasks people go through. And we think of like midlife crisis. We've heard of that. The ones that happen later in life, the older senior, 2 of them, control and legacy. Control is, I feel like I'm losing control. My body doesn't work the way it used to. My mind maybe doesn't. My daughter actually marched into my house the other day and said, "Mom, I don't think you should live alone anymore. I think you should move. And I think you should do that right away so you're safer. And I made an appointment at the assisted living down the road. Let's go do that." Did you know that happens a lot to older seniors? Literally, this person comes in and starts bossing them around. How would you like it if I did that to you? You'd be like, "You're not the boss of me. Get out of my house. What do you think? Who do you think you are?" But this happens a lot to seniors. And when you start trying to control a senior, what do? Resist, right? Legacy is what it sounds like. Did I matter? Will anyone remember me? Did I make a difference, etc.? So here we go. Slowing down when aging. A lot of it's pretty normal because their legacy needs, thinking about how their life turned out and what matters, takes thinking time. They're not doing as much. They're pondering and processing. Middle-aged people, they march in there and say, "Okay, we've got to get back to carpool. I've got to get back to work. Go, go, go. Let's take care of this. Do what I say." Professionals working with people, same thing. "We have 15 minutes for this appointment." "No, 7.5. Let's go. I got to get you to buy into this plan. You should do this." And the senior's like, "Slow down. What's the rush? You're not the boss of me." Right? And there's a lot of conflict. All right, I know that I became middle-aged at age 45 because it was literally like a light switch that changed. I was really relaxed, and then all of a sudden it was like very driven. I can't wait to be old so I can ponder again. Okay, so here we go. Here's his magic technique. Since control is the big motivator, and if we keep pushing, they're just going to resist, we shift the conversation. Most of this conversation is the one you already have. "Well, if you don't use your walker, you might fall and hit your head." People say, "I already say that to people." I'm going to say it differently. I'm going to say, in the short term, of course, you can choose to not use your walker. You're a grown man. You can do what you want. I'm not the boss of you. It's your decision. Does this person like me? Yeah, because I said what is true. He is in charge of his life. He can choose not to use his walker. Then I'm going to say, with a sigh usually, I don't say "but" because that negates what I just said. I'm going to go, "Oh, it worries me though," or it does concern me that in the long term, if you don't use your walker, you may be sacrificing long-term control, because if you do fall and hit your head or break a hip, you'll have to move to a nursing home or someplace like that. You will have to eat what they cook. You'll have to be on their schedule. You'll have to do what they say. You might be giving up a lot of long-term control. Then I take a moment, so I make sure that got in there. And then I'm going to say, "But of course," well, I'm actually not going to say "but," bad. I'm going to say, "Of course, it's your decision." And I'm not going to expect them to make a quick decision. I'm going to plant the seed. Short term, of course it's your decision. Long term, you may be, magic words, sacrificing long-term control, and then I back off. And you have to tell the family, back off. Because the next time you see this person, most likely they'll be like this. "I don't like using this, but I don't want to fall and live in that nursing home. I'll use it." Right? Because we put it in a developmental task and stage that they could relate to, and we put it in terms they could understand. They're not doing it because we told them. We're doing it because it makes sense to them. Okay? So I know we're finishing up right now, and I think we're probably done. This is my last technique. It's a mediation technique where it's called separating the person from the problem. Basically, when two people are arguing or you're trying to navigate two people who are arguing, you create a third person in the room called the problem. That falling problem. I don't put Bob's falling over there or you falling. I just put the falling problem. and I say, how can you and I, or how can the three of us figure out how to solve that falling problem? And what happens is, instead of the patient being the problem is the problem, and we're working in it together. So thank you very much. I appreciate it. Thank you. I've given you some low literacy content and resources.